Okay, so if you know me, you'll already know who I am. But for those of you that don't, here's a little bit of information about me. I'll be really quick because this isn't about me, but I think it's good for you to know that I am speaking from a relative place of experience. So I'm a lymphedema therapist, a scar tissue therapist, and a holistic lifestyle coach. And I've worked in healthcare since 2003. I've worked with post-op patients since 2006. And at that point, it was mostly with ladies who had had radical mastectomies and were experiencing pain and discomfort and reduced movement in their shoulders. In 2010, I received my first post-op referral from Dr. Dennis Wolfe of the Private Clinic in Harley Street. That was a patient that had had Vaser liposuction, and I had never heard of Vaser before. And to be honest, I had no clue what I was doing. Dr. Wolfe explained the procedure to me, and so began my career treating post-op patients. In 2011, I moved to London, and later that year, I introduced an integrated MLD into London Bridge plastic surgery. And I'm very proud to say that this is my legacy. LBPS was the only plastic surgery in the UK at that time to offer MLD to all their surgical patients as part of the surgical care package. Every person having a surgical procedure had 4 sessions of MLD included in the price of their procedure. And Chris Inglefield now tells all his patients and staff that MLD is non-negotiable. It would be great if all plastic surgeons had that same mentality. When I started off working there, I wasn't confident at all. I left work often wondering if what I had done had in fact benefited those patients, or could it have been detrimental to their recovery. I was fortunate to have a clinical nurse specialist and of course the surgeon at hand if I was unsure or worried about a patient. And gradually over the months and years working there, I gained confidence through experience and knowledge from asking a lot of questions. In 2015, I set up my own clinic in Harley Street and in Maidenhead in Berkshire, England, where I treated patients from all over the world following surgery for cancer, plastic surgery, and lymphedema. And I've been extremely fortunate to have worked alongside some of the UK's leading specialists in oncology, lymphedema, lipedema, venous disease, and of course, plastic and reconstructive surgery. And because of this, I've learned a lot in the 20 years of my career, and I'm delighted to be able to share some of that knowledge with you this evening. So this is what we're going to cover tonight. Please note down any questions that might crop up during the presentation, and you will have an opportunity to ask at the end when I'll go through the questions, and I'll try and answer as many as I can within the time that we have. Just also, I'm going to pop in and say here, if you're interested in any further training, I'll give you some information on the training programs I have available at the end. So what are post-op complications? Post-op complications are problems which arise because of having surgery. Complications is a term that healthcare professionals use to refer to something which is not intended to happen. Surgeons are aware of the risks that can occur during and after surgery, but often the patient isn't. The most common post-op complications are fever, small lung blockages, infection, pulmonary embolism, and DVTs. However, the complications that post-op therapists often encounter will be addressed further in the presentation. Complications can occur from as soon as the surgery starts right up to years afterwards. And this slide shows you the most common complications. As post-op therapists, it's unlikely you'll encounter anything in the immediate and late columns, but often you'll come across the complications listed in the early column, and more often, some you'll come across more often than others, and some you may never come across. But it's important you know what they are, how to recognize them, and what to do if you encounter them. I'm going to do a lot of talking on this slide, so just bear with me and take some notes if you need to, but also this will be available for replay afterwards. So complex complications, it's very unlikely you'll come across any of these in your post-op patients, but it's important to know that these do occur. Septicemia isn't common. It's a widespread, overwhelming infection spreading through the body, carried through the bloodstream. It often arises from a wound infection, pneumonia, or a bladder infection. It's more likely to happen after abdominal surgery if the surgery involves cutting the bowel. Contaminated wounds or severe burns can also contribute to septicemia. If the immune system is compromised, for example, if someone is diabetic, elderly, or very young, or on long-term steroids. Atelectasis. This involves a blockage, then collapse of part of a lung, usually at the bottom, so that it no longer fills with air on inhalation. It can occur after abdominal or chest surgery and happens when the finer airways get blocked with trapped mucus. Once air can't get in or out, the air that is already behind the blockage is absorbed by the body and the fine air tubes collapse. These collapsed sections of the lung easily become infected due to bacteria being trapped. Atelectasis is more likely to happen if the patient is overweight, a smoker, in a lot of pain and can't cough, or on high level of pain medication, which often suppresses coughing. Signs are breathlessness and painful cough. Pneumonia is an infection in the lungs and is surprisingly less common than atelectasis and can often follow it. Signs are a cough, high temperature, and shortness of breath. DVTs can occur when clots form in the large veins in the legs or pelvis. Pulmonary embolism occurs when bits of the clots come loose, enter the circulation, and end up in the lungs. PE is extremely serious and can be fatal. Patients are at risk of DVTs and PEs anytime after surgery until they start mobilizing, the highest risk being within the first 2 to 3 days. Painful swelling in the lower leg, shortness of breath, chest pain, and confusion are signs of DVT. If the surgeon thinks a patient may be at risk, they will prescribe blood thinners, and all patients are encouraged to wear lower leg compression until they are fully mobilizing again after their surgery. Aspiration pneumonitis is a rare complication. It is chemical inflammation of the lungs and occurs when acidic stomach contents are inhaled, usually due to vomiting or regurgitation, followed by inhalation whilst under anesthetic. It's more likely an emergency surgery than elective, as patients will be instructed to be nil by mouth prior to their surgery. Acute respiratory distress syndrome, another serious condition which requires intensive care. It's more common if the patient has sepsis, a traumatic head injury, serious burns, or has inhaled harmful substances, including smoke inhalation and near drowning. It can also occur because of aspiration pneumonitis. Heart complications generally occur within 48 hours after surgery, although can happen within the first 6 days. These include heart attack, abnormal heart rhythms, angina, and heart failure. These occur because of the physical strain and challenge of surgery, including the anesthetic, the surgery itself, and the meds and fluids given during surgery, causing extra load on the heart. A healthy person's heart can cope with all this extra work. Surgeons and anaesthetists will do a thorough assessment prior to surgery to ascertain any risks. Acute kidney injury may occur due to the body being, Acute kidney injury may occur due to the body not being given enough fluids during the surgery to help them process medications and chemicals produced by the body as a response to the trauma of the surgery. If this happens, the kidneys will simply shut down and stop working. And if you've worked with liposuction patients or those who've had mastectomy and reconstructive surgery after breast cancer, you will no doubt have come across those who lose feeling for weeks, even months after their procedure. Some nerve damage is impossible to avoid. Nerves grow back very slowly. It may take years for sensation to fully return, but sometimes sensation may never return. However, minor nerve damage in the skin and superficial tissues will usually resolve, except if the nerves get caught up in scar tissue. Patients may be left with localized areas of numbness. General complications, or these are more common complications. Confusion is very common after surgery. Anesthetic is often the cause, or strong pain medication for when the patient gets home. Lack of sleep, constipation, infection, and dehydration may also contribute. Nausea and vomiting, again, very common reaction to general anesthetic or pain medication. Raised temperature is a sign that something else is going on. If your patient reports an increase in temperature, they should consult their surgeon. Bleeding of any sort is more common and normal after long and major surgeries. However, heavy bleeding may mean damage to large blood vessels or stitches that have burst, or could mean clotting isn't successful. If this happens, the patient will need to return to theatre for investigations. Being a post-op therapist, you will see bruising often. This is basically leakage of blood from damaged vessels into the subcutaneous tissues. It will be more obvious in pale-skinned people, and there are some populations of people who are more susceptible to bruising, or where bruising will be more evident. And those are those on anticoagulants, someone with Ehlers-Danlos syndrome, someone with lipedema, people with red hair and pale skin, the elderly, and those with nutritional deficiencies, lacking vitamin K, clotting disorders, and those with liver disease. Complications following vasor liposuction. Lymphedema is an uncommon consequence of liposuction. If the liposuction is aggressive, where there is excessive destruction and obliteration of lymphatics, and if the edema doesn't resolve after 2 to 6 months, lymphedema may occur, perhaps due to an undiagnosed underlying primary lymphatic issue. However, most post-liposuction lymphedema will resolve within 6 months. It's important to note that high-pressure compressive garments may cause the delicate lymphatic capillaries to collapse, impeding lymph flow and effectively block lymph drainage. So please monitor your patient's compression garments. Tighter is not always better. We all expect there to be swelling after liposuction and any surgery due to the trauma exerted on the body. This can be minimized by using post-op care that includes, wait for it, incisional drainage and bimodal compression. Now, when I am talking about incisional drainage, I do not agree with incisions being opened and fluid being pushed out up to 7 days afterwards, but this is a topic for another discussion. Excessive liposuction may be associated with massive post-op edema, referred to as amplified liposuction edema. This is a potentially dangerous type of edema. If it's localized to the treated areas, it's mild. However, in progressive forms, edema can spread to distant sites of tissue, resulting in massive weight gain and systemic complications, such as acute renal failure and pleural, peritoneal, and pericardial effusions. In extreme cases, patients may suffer fatal pulmonary edema and end-stage central nervous system edema. Skin and tissue necrosis may follow lipoburns if the damage is extensive. This is caused by the surgeon often being too aggressive and scraping too close to the skin surface. Liposuction along with abdominoplasty, where there are large seromas or hematomas, increase the risk of necrosis. Loss of sensation is common afterwards, but sensations generally return to nearly normal by the end of 12 months. Chronic pain is rare and may be due to neuroma or damage to underlying fascia. If the pain is unrelenting, surgical intervention may be required to release scar tissue. Hypothermia is rare and associated with adverse cardiac events, increased surgical bleeding, infection, sepsis, and delayed healing, and DVTs I mentioned earlier. Seromas, also mentioned in a previous slide, is very common after liposuction, especially after aggressive lipo, if a cavity is formed or there is significant damage to the lymphatics. Misuse or incorrect use of compression garments can also contribute. Generally, seromas are detected by the 5th to 7th day post-op, and with additional foam padding under a compression garment may settle after 7 to 10 days. Areas most prone are lower abdomen and lateral and posterior thighs and lower back. Labial and scrotal seroma-like presentations can occur following lower abdominal and pubic fat lipo. I generally recommend foam padding or maternity pads to help with compression in those areas. Lipo burns, again mentioned regarding necrosis, can occur if the surgeon's techniques are too aggressive and is more common if the liposuction is followed by skin tightening procedures like Renuvion. So these are the most common issues you'll come across so let's see if we can play this. Doesn't appear to be playing. Okay, so the picture of the seroma was a young 21-year-old girl who went to Turkey to have her BBL, and for some reason the surgeon stitched the incisions closed and fluid wasn't able to drain out of the drain holes. She contacted a local plastic surgeon and it was aspirated. It's a shame that you can't see this because it is quite a big seroma, and it is that typical waterbed presentation. It's important that patients wear correct fitting compression plus foam underneath to help the tissues knit together again. Lipo burn can be caused by a surgeon being too aggressive and scraping too close to the skin surface, and if the compression is too tight, rubs on an already compromised dermis. There it's doing it now. Tissue necrosis here, as you can see, and a hematoma. I should add that these are not typically post-liposuction, but they are great visuals to show you both what might happen after any type of surgery. In fact, a hematoma is like a seroma, except it's a collection of blood rather than serous fluid. Wound infections are more common following abdominoplasty or paniculectomy, especially if there has been excessive amounts of tissue removed. Generally, skin redness and increased skin temperature will be a good sign of infection. However, sometimes a wound will need to be swabbed to confirm subcutaneous infection. Dehiscence is when a wound reopens. It's not terribly common and affects probably about 1 in 100 abdominal wounds. It can also occur in the T-junction of a scar after breast reduction or any breast surgery. Sometimes it will need to be restitched, and nutritional deficiency, infection, or inadequately secured stitches can contribute, as can coughing. Fibrosis. So this is one of the most common post-op complications that we will come across working with post-op patients. It is the typical lumpy, bumpy areas of fibrotic tissue and noticeable areas of adherence. The patient on the left had 8 liters of fat removed, and in my opinion, that is far too much. It's very aggressive, and I think surgeons are being more and more aggressive these days, and you can see that it actually gives a less than perfect outcome. The patient on the right had vaser liposuction followed by Renuvion, and this picture was taken 18 months after she had her procedure. In the top left hand of the picture, you can see a sizable scar, and this was where she had a really bad burn. Her injuries were so traumatic that you can see that her torso is slightly tilted and out of shape. So what is fibrosis? In normal circumstances, it is a pathological wound healing process where connective tissue proliferates. There is an excessive accumulation of collagen and extracellular matrix, which causes scar tissue. It's basically an exaggerated wound healing response. It should be noted here that for any lymphedema therapists, that post-op fibrosis should not be confused with fibrosis in lymphedema patients. Although the term is the same, the processes which cause fibrosis are completely different. So what contributes to the formation of fibrosis? There are numerous contributors to the formation of this issue, and I don't have time to go into them in depth tonight. It is definitely the subject for another webinar. And another little plug here, I have put together a separate little training program specifically for fibrosis, and it's included in depth in my advanced training. Without a doubt, the surgeon's skill and experience is vital when they are doing liposuction, and the correct selection of their patients. Excessive debulking isn't ideal because the longer the surgeon is in the tissues with the Vaser probe, the more energy and therefore heat is transmitted into the tissues. An unhealthy lifestyle of the patient, poor diet with not enough protein, and a balanced macro and micronutrient intake is important. Tumescence massage, I'm calling it, rather than incisional drainage, should only be done within the first 24 to 48 hours. And done correctly, it will help remove any remaining tumescence and inflammatory debris after surgery. I do not, and I'm repeating, I do not promote incisional drainage or the opening of incisions to drain out fluid. The lymphatic system is there for a reason, and that is to remove swelling from the body. And when you understand the stages of wound healing, in particular phase 2, the inflammatory phase, you will understand why incisional drainage may contribute to fibrosis and problematic scar tissue. Stress is also a contributor to fibrosis. Cortisol plays havoc with the wound healing process. Stressed patients have increased levels of cortisol in the blood that can slow the delivery of cytokines to the site of the injury, meaning that wound healing becomes dysregulated and wounds take much longer to heal. These are pictures of what fibrosis looks like under the surface. These are actually stills from a video that was taken by a surgeon who was doing a revision surgery and performing an abdominoplasty because the Vaser liposuction had left a lot of skin laxity. So there had to be an abdominoplasty done, but you can see that there is very little yellow fat cells in either picture. So the liposuction was successful. However, you can see the evident scar tissue and adhesions. So what do you do if you come across any of these complications? Never try to be a superhero. If in doubt, refer out. Don't take on anything that is outside of your scope of practice or that isn't covered by your insurance. It just isn't worth the risk. It's important to consider your level of knowledge. For example, do you know and understand the wound healing processes? If you are treating a patient, are you 100% sure the treatments you give are safe for that patient and their stage of wound healing? And what you're doing, so the treatments you're doing, are they supporting the patient's recovery or compromising it? So wound healing, I think, is something that all post-op therapists should take into consideration when they're working with this delicate group of patients. not only will the patient's pre-op lifestyle affect how they heal after surgery, but I believe the length of the procedure, how aggressive it is, and the amount of fat removed affects the stages of wound healing and therefore the outcomes. This is a really lovely visual of the various stages of wound healing. And if you're working with post-op patients, it's the inflammatory phase that you should pay most attention to. And you can see here, inflammation can last for 3 to 4 weeks. This is a quick video I'm going to show you of the inflammatory process. Hopefully it'll play.
Inflammation is a local immune response to tissue injury or infection, experienced as heat, redness, edema, pain, and loss of function. Immediately after injury, inflammation begins with brief vasoconstriction of the local blood vessels to reduce blood loss and formation of a clot to stop the bleeding. Then, stimulated by cell injury and death, local cells release vasoactive chemicals, such as prostaglandins and histamine, to dilate local blood vessels, leading to increased blood flow to the area. These chemicals also cause endothelial cells in small blood vessels to contract, opening spaces between them. This increased capillary permeability allows fluids and proteins to pass from the blood into the tissue. Next, during a multi-stage process called chemotaxis, circulating immune cells called neutrophils move out of the blood vessels to the site of injury and destroy pathogens and damaged cells. Chemotaxis begins when cells at the injury site release messenger molecules called chemoattractants, which cause local endothelial cells and circulating neutrophils to stick together. Next, in a process called diapedesis, neutrophils squeeze through the endothelial gaps. The neutrophils migrate to the injury site by following a chemotactic gradient. Upon arrival, the neutrophils encounter bacteria, engulf them, and digest them in a process called phagocytosis. After destruction of the bacteria and removal of cellular waste, tissue repair begins when locally produced growth factors cause local fibroblasts to begin dividing rapidly and secreting large quantities of collagen to reinforce the wound.
So I think it's, as you've seen there, I think it's really important to have a good understanding of each phase of wound healing and how each surgical procedure can affect those phases of wound healing. So how can patients prevent complications? Unfortunately, none of us can predict how a person will heal after the trauma of surgery. However, we can help them to be in the best shape possible before they have their procedure by improving their lifestyles preoperatively to include stopping smoking, reducing alcohol, being within a healthy weight, healthy eating. I try not to use the word diet. I know that I've got it here in the slide, but when I'm talking to patients, I try to eliminate the word diet because it has a bit of a negative connotation. And I'll try and use nutrition or lifestyle instead. Being well hydrated and following their surgeon's instructions is important, and they will have a better chance then of avoiding complications. I also recommend a great supplement called Skin Aid MD, and if you're interested about it, I can probably give you some information about it, possibly into the Facebook group. I'm not sure that I have the link to share this evening. Surgeons and anaesthetists will do extensive pre-op checks for things like blood pressure and anemia. They will administer antibiotics, and for more invasive procedures, they will always provide compression stockings to avoid DVTs. So what can you as a post-op therapist do? Continually monitor your patients. You will most likely be the next healthcare professional a patient will see after their procedure. So it's important you understand which each procedure entails and how that surgery affects the body and the patient and what the potential complications are. Become an expert in what you do so you can share advice and easily explain to your patient what you're doing and why you're doing it. Devise bespoke treatment plans based on the patient's presentation and their individual needs. Don't be a one-size-fits-all treatment provider. Incorporate additional therapies into your treatment sessions, and then you can charge accordingly based on your expertise. So the next few slides are a couple of additional therapies that I include in my treatment sessions. A-taping is brilliant for those tricky areas of swelling and can be worn under compression garments. So that anyone who knows me knows that I love the Lymphatic device. I've used it for about 6 years now, and it's been a wonderful addition to my treatment toolbox. And you can see this is the lady that we saw earlier who had the fibrosis, and the before and after is just a 45-minute treatment using a bit of MLD and the Lymphatic device, and you can noticeably see an improvement. Her torso is nicely extended and she is much more upright. Again, a combination of MLD and Lymphatic has smoothed out the tissues and much less lumpy and bumpy. I think this is after only one treatment. Bespoke foam inserts. Foam is a post-op therapist's friend. This is Mobiderm foam, which is great for fibrosis. Here I've cut it into bespoke pieces and it's easily inserted under compression garments. Post-op MLD, of course, the anatomy of the lymphatic system changes after surgery, especially if the surgery involves removing any tissue. So after abdominoplasty, some breast surgery as well. And this must be taken into consideration when you're treating your post-op patients. So that's it.